I'm Dr. FakhriRavari, and this is Intra-abdominal Infections in adults. Intra-abdominal infections are among the most common indications for emergency surgery and accounts for about 5% of all cases of sepsis in the United States. So unfortunately, people can die from intra-abdominal infections. The mortality rate of intra-abdominal infections in patients with sepsis is estimated to be as high as 37%, making them one of the infection types with the highest mortality risk. The majority of intra-abdominal infections are community acquired, so about 80% of them are in the community. And the remaining 20% are healthcare associated, that are most commonly acquired as complications of previous elective or emergency abdominal operations. So community acquired intra-abdominal infections is less likely to be due to resistant organisms, whereas healthcare associated intra-abdominal infections are more likely to be caused by resistant organisms. Intra-abdominal infections can take several forms and includes a variety of entities resulting from disease or trauma to both hollow and solid organs located in either the peritoneal cavity or retroperitoneal space. So let's take a look at a typical picture that you will see in a textbook showing the organs in the abdominal area. So you can see there is the liver, there is a stomach, there is a gallbladder behind the liver, there is the small intestine and the colon. What you can't see typically in these pictures is essentially the peritoneal space. So when we look at pictures from the side, you can see that essentially you have your organs. So here's the liver, and this is a picture in the female body, and you have your solid organs like pancreas, duodenum, and colon and small intestine, and you can see that these organs have a layer surrounding them, and this is essentially the peritoneum. And then the space between these organs that are contained within the peritoneum are the peritoneal space, and that's typically is normally filled with normal amount of fluid. And when you look at the male physiology, you can see something similar. So you have your solid organs. Here's the liver, and here's the stomach, and there is a layer of peritoneum. And inside the peritoneal cavity, there are fluids that are normally sterile. Now, retroperitoneal space is behind the peritoneal space. So retro means behind. So if you can see that, essentially in this picture, the darker color is the peritoneal space. When you see behind it is pancreas and duodenum, and this space between pancreas and duodenum, which is behind the peritoneal space, that's referred to as retroperitoneal space. That's present in both female and male. Now let's take a look at some reliable resources. So IDSA guidelines for complicated intra-abdominal infections were released in 2010 that included recommendations for diagnosis as well as management. So treatment recommendations are from 2010 guidelines. The AASLD, or the American Association for the Study of the Liver, also released guidelines in 2021, or rather guidance in 2021 for the management of ascites, spontaneous bacterial peritonitis, and hepatorenal syndrome. Some patients who are on peritoneal dialysis can also develop peritonitis as a result of dialysis, and ISPD, which is the organization for International Society for Peritoneal Dialysis, also has guidelines for management of peritonitis in those patients. And in critically ill patients, Society of Critical Care Medicine, or SCCM, released guidelines in 2023 for management of adult acute and acute unchronic liver failure in the ICU, which does include peritonitis. And most recently in 2024, IDSA released the first set of updated guidelines for complicated intra-abdominal infections, and this release focuses specifically on risk assessment, diagnostic imaging, and microbiological evaluation in adults. It does not have recommendations for treatment or management, and subsequent releases of the guideline will include recommendations for management. The first learning objective is distinguish between common types of uncomplicated and complicated intra-abdominal infections. Let's look at some definitions. So uncomplicated intra-abdominal infection involves only intramural inflammation of the gastrointestinal tract without extension into the peritoneal space. And so this is essentially localized at specific organs, so let's say the liver or the colon or some of those organs without extension into the peritoneal space. However, if uncomplicated intra-abdominal infection is not managed adequately, it can progress into complicated intra-abdominal infection. And by complicated intra-abdominal infection, we're referring to infection that extends beyond the hollow viscus of origin into the peritoneal space or an otherwise sterile region of the abdominal cavity, and it is associated with peritonitis with or without abscess formation. So essentially, if there is an infection in one of those organs and at the same time the patient develops peritonitis, that's essentially led to complicated intra-abdominal infections. Now again, about 80% of these infections are community acquired, so these are usually by the patient's own microflora. These are present within 48 hours of admission to the hospital. So in the first 2 days of hospital admission, if somebody develops intra-abdominal infection, it's considered community acquired because it takes time for organisms to grow and cause an infection. So if it's within 48 hours, that means it must have been growing from the community. And they occur in patients that do not have significant history of healthcare exposure. Now, for healthcare-associated intra-abdominal infection, it can be classified as either community onset or hospital onset. So if it's obviously if past 48 hours into the hospitalization that's developed, it's hospital onset. But also if it's in the community, but in the setting of a healthcare facility, for example, people who go get dialysis routinely, or somebody was getting surgery, those are typically community onset. Now let's take a look at the liver and the biliary system. So you can see that the here's the liver and here's the stomach, and the liver has many functions. For example, it makes proteins, including coagulation cascade proteins. It has an important role in detoxification and metabolism, including metabolism of fructose and alcohol and other substances, but also it has a role in production of bile acids. So bile acids are essentially made in the liver, and bile acid is the bile. I should say that essentially the liver makes the bile, and the bile includes bile acids. So it's essentially what's secreted is the bile. And bile acid is in the bile helps emulsify the large fat particles of the food into many minute particles, and then that makes it easier to digest. Now bile serves as a means for excretion of several important waste products from the blood as well. So that includes bilirubin and excesses of cholesterol that are handled by the liver, that they are released into the bile. Now, bile essentially gets released into the common bile duct as food comes through the stomach. And, there is an acidic environment that the food has to go through first, but then it will send a signal for this bile to be released into the common duct. There's also pancreas. Pancreas, essentially has the role of secreting insulin and, when appropriate, glucagon into the bloodstream, not into the GI tract. But pancreas has a role of releasing pancreatic juice into the duodenum that includes enzymes such as lipase. So essentially, bile will go down here, but also excess bile can be stored in the gallbladder. So you can see that the gallbladder is here. So as bile is released, excess amounts will be stored in the gallbladder for later use. Anytime there is fatty food coming into the stomach, it will signal the release of bile. Now, the problem with bile is that as it concentrates, it can turn into stone. So you can see here's the liver where the bile is produced, and occasionally it can form into stones that, a lot of the time they don't necessarily make an obstruction here. But these stones, as part of bile traveling into the gallbladder for storage, these stones can also travel and get stuck in the gallbladder, and they can actually get even more concentrated and grow and become bigger, which can essentially cause obstruction in the gallbladder. Now, causes of gallstones include, for example, too much absorption of water. So hydration is a good strategy for reducing the risk of gallstone formation, or too much absorption of bile acids from bile, or too much cholesterol in the bile, or inflammation of epithelium. So this is an overview of the biliary system. So keep in mind that the biliary system includes the liver, the gallbladder, the common biliary duct, and pancreas. Now, infections in the liver and the biliary system include liver abscess. So liver abscess is a focal purulent bacterial collection in the liver, and in general we think of it as amoebic liver abscess, which is due to parasites. But there's pyogenic liver abscess, which is due to polymicrobial infection caused by bacteria. And in this topic, we will focus on bacterial causes of abscess, not necessarily other causes. For cholecystitis, which is an acute inflammatory disease of the gallbladder, we think of it in two ways. A calculous cholecystitis, which is the large majority, about 90 to 95% of cases. This is due to gallstone, and the medical term for gallstone is cholelithiasis. So this obstruction from gallstone of the cystic duct is what drives the inflammation, and then the remaining 5 to 10% of cases are acalculous cholecystitis. So in the absence of gallstone, other predisposing conditions include, critical illness, immunosuppression, diabetes, non-biliary surgery, and childbirth. Then we have acute cholangitis, and this is essentially inflammation or infection of the common bile duct. And then lastly, we have acute pancreatitis, which is damage to the acinar cells in the pancreas, and we can think of it as interstitial edematous pancreatitis, which is about 80% of cases. And we can think of necrotizing pancreatitis, which is smaller, the remaining 20% of cases, which, essentially interstitial pancreatitis does not involve infection. Necrotizing pancreatitis, because it involves tissue death, and anytime you have tissue death, that means the immune system will no longer be present, and that can lead to an infection. So let's take a closer look at cholecystitis. So this is again in the gallbladder. So gallbladder is behind the liver, and we can think of it as calculus or acalculous. For calculus, essentially, it's due to obstruction from the gallstone. So as you have these gallstones form and get bigger and bigger, they can essentially obstruct the flow of the material in the gallbladder. And this can essentially build up pressure inside, and it can cause many issues, including, the hemorrhage and leading to necrosis of the tissue. And anytime you have necrosis of the tissue, it can lead to perforation, which means that, when you had an infection in the gallbladder, once it gets into the advanced necrosis and perforation, now you're going to have complicated intra-abdominal infections, because this material is going to go into the peritoneal space. Now you can see also in acalculous acute cholecystitis, this essentially does not involve obstruction from stones, but essentially something similar happens. So, various things can lead to bile stasis. So that's because of decreased bladder emptying. So, if things, if the bile is not exiting through the gallbladder, pressure can build up, and similar to the previous case, you will see that as pressure builds up, there could be necrosis of the tissue, and that can lead to perforation and formation of complicated intra-abdominal infections. Now let's take a look at pancreatitis. So acute pancreatitis, once somebody is hospitalized for that, 80 to 85% of cases are due to interstitial pancreatitis that do not require antibiotics. So with appropriate treatment of acute pancreatitis, patients will have resolution. The remaining 15 to 20% over the next couple of weeks will develop necrotizing pancreatitis, and again, about 70% of these patients will have sterile necrosis. So it's not all necrosis is infected. And about 30% of these patients who have necrotizing pancreatitis over the next couple of weeks, so overall it will take about 4 weeks to have infected necrosis, which is associated with high mortality of 30%, and these patients do require antibiotics. But one thing is to note is that nobody who has acute pancreatitis needs antibiotics initially at admission. It will take about at least 2 weeks before there is a decision to decide if people need antibiotics. So initially, people should not be on antibiotics. Now, infections in the lower gastrointestinal tract. So let's focus on the colon. So essentially, in a healthy person, this is what the colon looks like. Diverticulosis, which develops in about 30 to 40% of the population, and the risk goes higher as people get older. This essentially, there are small pouches that can develop in the colon. These are called diverticula, and essentially they form at weak spots in the walls of the colon, but they're not necessarily infected. The problem with diverticula is that essentially fecal matter can get stuck in diverticula, and as you can imagine, there is no mechanism to squeeze these material out of these pouches, so they can get stuck in there, but they don't necessarily cause an issue. But in about 4 to 25% of patients, this can lead into inflammation. So once there is an inflammation, that's when you have acute diverticulitis, and it could essentially lead to infection as well. And this is when patients will develop abdominal pain, and that's when they will essentially seek help from the healthcare providers. And lastly, since the appendix is at the end attached to the colon, acute appendicitis, which is the inflammation of the appendix, that's also part of the lower gastrointestinal space. And when we look closely at the appendix, so inside the appendix there are bacteria present as normal part of the microbiome. So the appendix does have a role in the human health, and that's specifically to house healthy microbiome. Now, as you can imagine, the appendix could potentially get obstructed due to many things. The most common cause of obstruction would be fecal matter getting stuck here, but also other things can lead obstruction here. And once that happens, again, the pressure will start to build up inside appendix, and this can happen actually pretty quickly. That can lead to inflammation, and potentially it can lead to necrosis of the tissue and perforation. And as perforation happens, essentially that's when you have complicated intra-abdominal infection. So this becomes a medical emergency. Now, once you are in the peritoneal space, that's essentially the definition of complicated intra-abdominal infection by, if any of those organs that get infected, if they advance into the peritoneal. However, not all peritonitis are due to another source of infection. For example, primary peritonitis essentially means that it was not secondary to anything else, right? Now, this is a very small percentage of all peritonitis cases, so about 1%. So the large majority of peritonitis is due to another infection. Primary peritonitis, for the most part, you can think of patients with cirrhosis, so spontaneous bacterial peritonitis. That is, in fact, what the spontaneous is referring to, that the infection started in the peritoneal space. It did not come from, like the pancreas or the gallbladder or other organs. The other option is people who are on peritoneal dialysis. Dialysis itself can be the source of infection directly into the peritoneal space. Now, secondary peritonitis, as I mentioned, is the most common, so 80 to 90% of cases, and it is caused by microbial or chemical contamination of the sterile peritoneal cavity from multiple disease processes. So this typically starts, with one of those other uncomplicated intra-abdominal infections and advance into secondary peritonitis. And the concept of tertiary peritonitis essentially refers to a persistent or recurrent infection without a surgically treatable focus. And it may be due to disturbance in the host's immune response and often is associated with less virulent and potentially resistant microorganisms. And lastly, there could also be intraperitoneal abscesses, which can occur secondarily as the consequences of diseased organs, penetrating trauma, or a surgical procedure. Now let's take a look at some clinical characteristics. So peritonitis, essentially patients will have loss of appetite, bloating, nausea, vomiting, abdominal tenderness. Fever may or may not be present on a physical exam. Bowel sounds are hypoactive. Now with peritonitis, pretty much acidic fluid is available, and on acidic fluid analysis, you will have leukocytes more than 250, that's essentially diagnostic criteria for peritonitis. And on imaging, essentially abdominal radiographs may show free air in the abdomen, which indicates perforation or distension of the small or large bowel. For abscess, again, there will be abdominal pain or discomfort. In fact, for pretty much all intra-abdominal infection, there will be some sort of abdominal pain in various regions of the abdomen. So you can think of it in quadrants, so upper left, upper right, lower left, and lower right quadrant, and that region can sometimes indicate what type of intra-abdominal infection. But regardless, abdominal pain is pretty much what leads patients to seek help. Now, fever is usually present for these abscesses, and ultrasound is the primary diagnostic method used when intra-abdominal abscess is suspected. However, CT is also useful. Now, for the 2024 IDSA guidelines, they have specific recommendations for imaging. So essentially for appendicitis, diverticulitis, and intra-abdominal abscess, they actually say abdominal CT scan is the initial diagnostic imaging modality that's preferred. Of course, if CT doesn't find anything and there is a high suspicion, other modalities can be used like ultrasound and MRI. With cholecystitis and cholangitis, the guidelines do recommend abdominal ultrasound as initial diagnostic imaging, but again, CT scan and other forms of imaging can be used. For microbiological assessment, the question is, do patients need blood culture and intra-abdominal culture? And the 2024 IDSA guidelines essentially say that blood cultures should be obtained in patients with suspected intra-abdominal infections who have a fever and one of the following. So either hypotension or tachypnea or delirium, or if there is concern for antibiotic-resistant organisms. So there are many risk factors for antibiotic-resistant organism. The most commonly is receipt of antibiotics in the past 90 days. For intra-abdominal cultures, which are useful to guide antimicrobial therapy in patients with complicated intra-abdominal infections or having a procedure for source control. So, anytime there is a procedure, it's easier to also obtain those fluids from the abdominal, from the peritoneal cavity or wherever the source of the infection is, to better manage antimicrobial therapy. Now, this is not routinely needed if patient is getting appendectomy for appendicitis. Essentially, removing the appendix, which is appendectomy, is very effective at treatment. So it's usually there's no need for follow-up antibiotics or culture. Now, for immunocompromised patients who are at increased risk of antibiotic-resistant organisms, and intra-abdominal cultures are generally warranted. We distinguish between common types of uncomplicated and complicated intra-abdominal infections. Now let's list common microorganisms associated with intra-abdominal infections. So when you look at different types of intra-abdominal infections, you can see that there is a large overlap between some of the common causes of these infections. So, for example, E. coli is pretty much always present. Klebsiella is always present on the list. And then on the gram-positive part, you can see that for the most part, there is Enterococcus species present. And on the anaerobic part, mostly Bacteroides. So it is easier to remember some of the ones that are, essentially not causing an infection. So, for example, when it comes to peritonitis, whether due to cirrhosis or peritoneal dialysis, you can see that there is no need to cover Bacteroides. So Bacteroides essentially don't need to be covered. These are anaerobes. When it comes to essentially Enterococcus, you can see that for appendicitis, Enterococcus typically not isolated. And then when it comes to as far as gram-positive, so essentially mostly Enterococcus except for appendicitis. But also note that Staphylococcus aureus is not present except for peritonitis. So for peritonitis, Staphylococcus aureus typically needs to be covered, but not necessarily MRSA. So just a simple MSSA coverage is sufficient unless there is evidence that the patient may have MRSA. For gram-negative, essentially E. coli should always be covered empirically, as well as Klebsiella, but not necessarily Pseudomonas. Now, with patients who are on peritoneal dialysis, Pseudomonas may be indicated, but essentially for the rest of them, Pseudomonas is typically not an indication unless certain populations within these infections that we will talk about when we talk about treatment. So let's talk about Bacteroides. Essentially, Bacteroides is a genus of gram-negative, non-spore-forming, obligately anaerobic rod-shaped bacteria. Say non-spore-forming, to contrast this from Clostridia species that are, spore-forming, but those are gram-positive anaerobes. So Bacteroides are gram-negative anaerobes, and there are more than 30 species of Bacteroides that have been recognized, and several Bacteroides species express numerous capsular polysaccharides. And first of all, I would say that these organisms typically are part of a healthy microbiome, so normally they are not causing a problem. It is only when they cause intra-abdominal infections that becomes a problem that needs to be treated. And this capsular polysaccharide has a role because the host response to the capsular polysaccharide of B. forage results in abscess formation. So that's something to keep in mind. And perhaps in the Bacteroides genus, Bacteroides fragilis or B. forage is the most famous one. Now, E. coli and B. forage can also act synergistically, and both are often isolated from intra-abdominal abscesses. So that's something to keep in mind. And B. forage essentially they can express beta-lactamases, and these beta-lactamases are essentially penicillinases, so not necessarily cephalosporinases. So their mechanism of resistance to cephalosporins is a bit different. But for penicillins, essentially any penicillin that's active against B. farad should have a beta-lactamase inhibitor on board. So when we look at some of the selected antibodies, so you can see on the right-hand column is Bacteroides. So you can see ampicillin not active, but ampicillin sulbactam is, or piperacillin tazobactam is. And what's not on the table is, for example, amoxicillin is not active, but amoxicillin clavulanate is. Then you have your cephalosporin. The large majority of cephalosporins are not active except cefamycins, for example, cefoxetine and cefotetan. Those are active against Bacteroides. All of carbapenems are active against Bacteroides. And when it comes to clindamycin, the activity against Bacteroides over time has gone down. So nowadays, clindamycin has poor activity against Bacteroides, which was not necessarily the case in the past, but currently it is. The same is true with moxifloxacin. So moxifloxacin has relatively lower activity against Bacteroides. Other fluoroquinolones don't have activity against Bacteroides. Early tetracycline, so doxycycline, minocycline, and tetracycline itself don't have activity against Bacteroides, but some of the newer tetracycline derivatives, such as tigecyclines and ribociclin, have activity against Bacteroides. And of course, the king of anaerobic coverage is metronidazole, or flagyl. This has excellent activity against Bacteroides. In fact, it has activity against nothing else, as far as bacteria, but excellent activity against anaerobic bacteria, including gram-positive or gram-negative anaerobes. Some of the things that are important to note here is Enterococcus. So Enterococcus, in general, we think of two organisms, Enterococcus faecalis on the left-hand side and Enterococcus faecium on the right-hand side. And faecium tends to be more resistant to antibiotics, and also faecium is more likely to be a vancomycin-resistant Enterococcus, so it's most likely to be VRE, whereas faecalis is less likely to be resistant and is less likely to be resistant to vancomycin. So for faecalis, when susceptible, ampicillin, pretty much penicillins have good activity, but none of the, essentially cephalosporins in general are not good for Enterococcus. There are a couple of exceptions for faecalis. For example, ceftaroline might have activity. Erdopenem, meropenem don't have activity against Enterococcus. Bactrim doesn't. Clindamycin doesn't. In general, fluoroquinolones have poor activity. Doxycycline may have better activity against faecalis than faecium. And again, tigecycline better activity against faecalis and faecium, including if there is VRE, tigecycline may still be active against it. Other things to note for intra-abdominal infections is Viridans-group strep. So essentially, beta-lactams have excellent activity against this group of streptococci. Bactrim does not have activity. So Bactrim in general has good gram-positive activity, except for Enterococcus, Viridans-group. Otherwise, Bactrim has good activity against beta hemolytic strep, against MSSA and MRSA, community-acquired MRSA. Clindamycin is also active against Viridans-group strep. Some of the newer fluoroquinolones, so levofloxacin and moxifloxacin, that have good gram-positive activity. Doxycycline has poor activity against Viridans-group, and tigecycline has great activity. For E. coli specifically, ampicillin sulbactam has poor activity against E. coli. So that's something to keep in mind. Whereas amoxicillin clavulanate, for example, has much better activity against E. coli. That's not in this table, but amoxiclav does much better than ampicillin sulbactam. Other things you can see on this table. We distinguish between common types of uncomplicated and complicated intra-abdominal infections and listed common microorganisms associated with intra-abdominal infections. Now, given a patient with an intra-abdominal infection, let's recommend appropriate treatment. Let's take a look at treatment of some uncomplicated intra-abdominal infections. These are in the absence of peritonitis. For pyogenic liver abscesses, essentially surgical drainage plus empiric antibiotic are recommended. And for monotherapy, essentially piperacillin tazobactam or a carbapenem, including erdopenem, is recommended. For most patients, piperacillin tazobactam is the way to go. For patients who are at risk of resistance, then carbapenem. When there is a need for ESBL coverage, erdopenem is the drug of choice. For combination therapy, instead of piperacillin tazobactam, we may use either a third generation or a fourth generation cephalosporin plus metronidazole for Bacteroides coverage. Obviously, piptazo and carbapenems do cover Bacteroides, so there is no need to add metronidazole to carbapenems or piptazo. Alternatively, ciprofloxacin or levofloxacin or moxifloxacin could be used in combination with metronidazole. Now, parenteral treatment for 2 to 3 weeks is recommended, and then a 4 to 6 weeks total course is completed using oral agents. So in general, duration of treatment for pyogenic liver abscesses could be quite long. For uncomplicated acute cholecystitis, cholecystectomy is effective treatment. Antibiotics should be used before and at the time of surgery, essentially for surgical prophylaxis to prevent surgical site infection, but not indicated post-operatively. So essentially, once the gallbladder is removed, there is really no need for antibiotics. For uncomplicated acute cholangitis, decompression or drainage of the biliary system is the effective treatment. Empiric antibiotics may be used and treatment for 4 to 7 days once source control is obtained. When it comes to diverticulitis, essentially surgical intervention is recommended, and essentially the sections of the colon that have these diverticula will surgically be removed, and then the end of the colon will be attached. So essentially removing the segment that was surgically removed, and the site where this is reattached is essentially, the terminology is reanastomosis, and antibiotics may not be necessary for this patient. Outpatient oral treatment for 7 to 10 days has been suggested, but it is not clear if there is a benefit to giving these outpatient antibiotics. For uncomplicated acute appendicitis, again, appendectomy is a very effective treatment. Alternatively, patients who do not want to get appendectomy, they may receive either IV antibiotics for 10 days or initial IV transition to PO antibiotics. And recommendations include erdopenem, combination of cephalosporin plus metronidazole, or oral fluoroquinolone plus metronidazole. Once the patients have received surgical intervention, there is really no need for antibiotics post-operatively. Now, for complicated intra-abdominal infections, one thing that's key is to identify patients who have high risk for failure of source control. There are several risk factors for this. The most important are delay in the initial interventions, more than 24 hours, or a high severity of illness using the Apache 2 score. The Apache 2 score essentially, the higher the score, the higher the risk of mortality. Advanced age is defined as age over 70 years old, or if the patient is immunocompromised, and there are a few other risk factors on the list. So when it comes to treatment of extrabiliary complicated intra-abdominal infection, essentially you need to think whether the patient has high risk for failure or so if the patient has any of those risk factors, they will be considered high risk. Otherwise, the patient will be mild to moderate with no risk. So if there is, mild to moderate severity, there is no need to cover Pseudomonas. So monotherapy includes either, you essentially want to cover E. coli, Klebsiella, and Bacteroides. So cefoxitin monotherapy, ertapenem monotherapy, or tigecycline monotherapy, or a combination of either cefazolin plus metronidazole or cefuroxamine plus metronidazole. Essentially some cephalosporins plus metronidazole or a fluoroquinolone plus metronidazole. Now, for high risk, essentially Pseudomonas needs to be covered. So the monotherapy options includes piptazo or a carbapenem that covers Pseudomonas specifically. And for combination therapy, it's something that covers Pseudomonas, cefepime, ceftazidime, cipro, or levo, plus coverage for Bacteroides. So metronidazole will be added. Now, for community-acquired complicated intra-abdominal infections, when we look at acute cholecystitis, again, we look at those risk factors, so high risk and mild to moderate severity. So mild to moderate, again, there is no need for pseudomonal coverage. So cefazolin, cefuroxime, or ceftriaxone. Now, for cholecystitis, there's no need to cover Bacteroides specifically for these mild to moderate severity patients, and obviously no pseudomonal coverage. For high-risk patients, there is a need to cover Bacteroides as well as Pseudomonas. So piptazo, carbapenem, cefepime plus metronidazole, or fluoroquinolone plus metronidazole. When it comes to treatment of complicated cholangitis following bilioenteric anastomosis, one thing that's different is that it doesn't matter if it's mild to moderate or high risk. Essentially, all patients need to have pseudomonal coverage. But also they need MRSA coverage. So vancomycin should be added to any of these agents. Now let's take a look at some recommendations. So for anaerobic cultures, essentially anaerobic cultures are not necessary if empiric antimicrobial therapy is active against common anaerobic pathogens. For high-risk patients, cultures from the site of infection should be routinely obtained, particularly in patients with prior antibiotic exposure who are more likely than other patients to harbor resistant pathogens. As mentioned before, ampicillin sulbactam does not have good activity against E. coli, so therefore, it is not recommended. Aminoglycosides are not recommended essentially because of toxicity, and we have many other agents that can be used. In general, empiric coverage for Enterococcus is not necessary, even though Enterococcus is isolated in many of these intra-abdominal infections. Again, Enterococcus, belongs to the normal gut microbiota. Now, occasionally patients may grow candida on these cultures in intra-abdominal infections, and that may not necessarily be causing an infection, so empiric antifungal therapy for candida is not recommended. Fluoroquinolones should not be used unless antibiograms indicate more than 90% susceptibility to E. coli. Aztreonam plus metronidazole is an alternative, but addition of an agent effective against gram-positive cocci is recommended. So remember, metronidazole and aztreonam have absolutely no gram-positive coverage. Now, empiric use of agents effective against enterococci is recommended for community-acquired high-risk complicated intra-abdominal infections. Use of agents effective against MRSA or Candida is not recommended in the absence of evidence of infection due to such organisms. And lastly, antimicrobial regimens should be adjusted according to culture and susceptibility reports to ensure activity against the predominant pathogens isolated in culture. Now let's take a look at spontaneous bacterial peritonitis. So essentially the diagnosis is based on acidic fluid analysis showing PMN of at least 250 cells per cubic millimeter or more. Now, older AASLD guidelines also had mentioned that if the PMN is less than 250, but if the patient has either a fever or abdominal pain, that also is diagnostic of SBP. For treatment, essentially an IV third generation cephalosporin is recommended. Most often people use ceftriaxone because of easier dosing. It can be dosed once a day. And that's for community-acquired SBP. For healthcare-associated SBP, it is important to use a local antibiogram to make sure that we use an agent that's appropriate. Often, piperacillin tazobactam may be necessary. And vancomycin should be added if prior MRSA infection or a positive surveillance swab for MRSA is found in the patient. In the case of VRE, instead of vancomycin, daptomycin should be used. For, if the patient has had a recent exposure to piptazo should be replaced with meropenem. In critically ill patients, it is recommended to use carbapenem-based therapy as opposed to starting with piptazo. And total duration of antibiotic use for treatment of SBP should be 5 to 7 days. Now, what about preventing SBP? So there is the concept of primary prevention of SBP. So this is someone who has never had the SBP before. So we're trying to prevent this for the very first time. And certain patients qualify for primary prevention. The most, the biggest one is essentially patients with cirrhosis who have upper GI bleed. And when they have that GI bleeding, because that can lead to SBP, it is recommended to give IV ceftriaxone for up to 7 days. Now, other patients, cirrhotic patients who have low protein ascites, primary SBP prophylaxis can be considered if they have renal dysfunction. So, for example, serum creatinine greater than 1.2, BUN greater than 25, or serum sodium less than 130, or if they have liver failure. And the agents for primary prophylaxis for these patients essentially is ceftriaxone, but trimsulfa and ciprofloxacin have also been used. These are all for 5 days. So essentially, prophylaxis from GI bleeding is a bit longer compared to other types of primary prophylaxis. And then once somebody has had SBP and received treatment, then you can do secondary prevention. So secondary SBP prophylaxis is to prevent other SBP occurrences. And unfortunately, these patients who have had SBP, they don't live very long. So their life expectancy is quite short. So these are very difficult to study. So when you see this recommendation, they say indefinitely, but keep in mind that these patients may not have many years left to live. So ciprofloxacin daily is recommended, and as you can imagine, this is going to have a huge effect on causing collateral damage. So people have also tried by mitigating it by using ciprofloxacin once a week instead of daily, and also there has been rifaximin at 400 milligram TID dosing, which is not in the guideline, but people have studied this and have tried this. This is more expensive, but it could be beneficial in patients who have E. coli resistant to ciprofloxacin or Bactrim. This concludes this presentation.